I am now pleased to introduce our first speaker, Dr. Don Berwick. Don began his career as a pediatrician and is a leading authority on healthcare quality and improvement. He is a former administrator of CMS and currently serves as President Emeritus and Senior Fellow of the Institute for Healthcare Improvement, which he co-founded. Don also serves as an advisor to NIHCM, and we're so fortunate to have him with us today. Don?
Thank you so much, Catherine. Thank you for the chance to join you all. I'm stunned by the level of interest in this topic, and I can't wait to hear my co-speakers. And let me also extend my thanks to Nancy Chalkley for her incredible leadership of NIHCM and NIHCM Foundation. It's a privilege to be associated with this great education and research organization. I'm going to basically lay a groundwork. My colleagues are going to, I think, offer the good news. I'm going to start with some of the bad news. I want to talk a bit about the challenges we have around happiness, health, and well-being, and especially social isolation, and give you a little bit of a peek at the scientific underpinnings of the problem we're trying to solve. I want to defer, give credit to my mentor, Sir Michael Marmot from the UK. Michael is one of the world's experts on the issues we're dealing with, basically the social determinants of health. And if you have not read Sir Michael's book called The Health Gap, which appeared in 2015, it is my text, my Bible on this field. It's a wonderful book, and it lays out not just issues around happiness, isolation, and well-being, but also the greater terrain of what we really now call social determinants of health. Social determinants of health is a widely used term right now. You're hearing it a lot. The question is, what does it mean? And that's what I want to unlayer and what I want to connect back to our topic today about isolation, loneliness, health, and well-being. The phenomenology is disturbing. We know from research, this most recent paper, especially by Steve Woolf and Heidi Schoomaker, that appeared in JAMA, but it really summarizes growing epidemiologic data on life expectancy, mortality, and well-being in the United States. And the basic news is we have lost ground. For the first time in my lifetime, life expectancy decreased for people in their middle years in the United States. That got leveled off last year, but for the 3 prior years, for the first time on record, life expectancy decreased steadily. And that's not an accident, nor is it minimal. The overall pattern of life expectancy has taken a turn. It's important, though, to realize that life expectancy growth has always been an unevenly distributed benefit in the growth of American society. This graph between the 1920s and nowadays shows that although life expectancy improved quite quickly for people in middle income and the wealthy, if you were at the lower end of the spectrum as a man or as a woman, your life expectancy did not increase during that period. In fact, if you were born in 1950, your life expectancy was lower than if you were born in 1920. If you were a woman in the poorest part of our economy. What's going on here has very little to do with health and healthcare. It has to do with factors in people's lives that are very, very strong determinants of life expectancy. Let me show you how this looks, for example, in the city of New York now, one of the epicenters for the COVID epidemic. If you are a New Yorker in Midtown Manhattan, boarding the subway, one second, I got to make this work properly. Boarding the subway, say at 85th Street in Manhattan, Midtown Manhattan, people walking on the sidewalk above you are making about $180,000 a year. They're mostly white. They're well dressed. Their kids are in good schools, and your life expectancy is high. It's about verging towards 80. Excuse me, I'm messing up my slides. I apologize here. Life expectancy in that Midtown Manhattan area is, sorry. Here we go. Is about 85 years, close to what it is in Japan. If you travel north about 2.5 miles to the South Bronx, the epicenter of the COVID epidemic right now in New York, your life expectancy is much shorter. The delta, the difference in life expectancy, is about 10 years. That means on the D train traveling from Midtown Manhattan to South Bronx, you're losing about 6 months of life expectancy for every minute you're on the D train, about 2.3 years per mile traveled. That's an extraordinarily big effect compared to anything healthcare ever does. What's going on between Midtown Manhattan and South Bronx? Well, that's what we call social determinants of health. It has to do with the circumstances of your life way beyond the accessibility of healthcare. This has been given even more force, as you've been reading lately. A wonderful summary, by the way, by Atul Gawande in the New Yorker of the book Deaths of Despair, which marks the research of Angus Deaton and Ann Case, two Princeton University economists. Angus Deaton himself is a Nobel Prize winner, who has studied a really interesting phenomenon, a tragic phenomenon, which is this surge of deaths in the United States from conditions which they call conditions of despair. Drug abuse deaths, alcohol-related deaths, suicide deaths, numbering close to 50 or 60,000 deaths a year now, something we've never seen before in this country, not as Deaton and Case have documented it. This is a particular kind of version of social determinants of health. Now, among the components of this, the deaths of despair, the loss of life expectancy, especially for people who are impoverished, is the issue of social engagement. It has to do with whether people feel connected to, empowered by, in relation to their society and to others in society. This slide shows a study published not just in 2010, not that long ago, about social relationships and risk of mortality. And if just take a look at the magnitude of this effect, you're seeing risk ratios. I think we need someone to mute their phone. The risk ratio is like a 1.5 times risk ratio for better survival for people who are socially integrated, whereas social isolation, living alone, and loneliness are associated with a decrement of about 1.5-fold for survival. That's an incredibly large impact on the probability of survival in this study. A particularly interesting study that I showed in a prior NICM webinar was this one published in the journal Heart in 2016, relating social relationships to cardiovascular risk. Coronary heart disease risk incidence of coronary heart disease went up 29% among people who were judged, who scored high on loneliness and social isolation. Stroke risk goes up 32%. Those are massive numbers. I want to emphasize, we don't know any medical or surgical intervention on either coronary heart disease or stroke that even vaguely approaches this level of impact of this toxic effect of loneliness. It's a very, very severe cause of poor health. The mediator, we don't know. It's the mind. It's that somehow there are connections between our state of mind and our well-being. The obvious connection is mental illness. That's a state of mind issue. Illnesses that are treated because of treated through neurologic interventions, but the psychosocial pathways themselves, the psychology of loneliness, the psychology of stress, we know are very, very strongly related to physical illness, as you just saw. Now I have to get a little political, which is why does this happen? Why in a wealthy society do we see this phenomenology of despair, deaths of despair, loneliness and isolation and its consequent effects on health? And the answer is poverty. The associations between despair and loneliness are not, and poverty are not 100%. You can be wealthy and quite lonely also. But there is a really interesting and strong connection in our country between being of lower income or poor and these conditions. And you can see that this kind of poverty is heavily concentrated in people in underrepresented minorities, in Black, Latino, and Native American race. This is racism at work, and this is where I have to get clear. This is a 1937 guidance from the Homeowners Loan Corporation around mortgages, who it's okay to give mortgages to. More than half of the Negro population of San Francisco, says this government manual, are located in the red areas, considered a highly hazardous area. This is what you know as redlining. It's racially constructed redlining, which is part of our nation's history in law. The other thing I want to, one second. If you take that redlining and you now look at today at what's happening with poor academic performance in schools or in age-adjusted preventable hospitalization rates, for example, the redlining characteristics on the racism map from the 1930s correspond directly to the morbidity patterns and the poor education patterns in San Francisco. This is the legacy of racism being played out through all these social factors in terms of the health and well-being of the population. Now, part of this is mediated by our attitudes toward poverty, and this is something I stumbled on thanks to Alice Chen in San Francisco last year. This has to do with our federal poverty line. As you probably know, under the Affordable Care Act, for example, whether you're eligible for exchanges and exchange subsidies depends on where you are with respect to some multiple of federal poverty line. States and the federal government use the federal poverty line to determine whether you're eligible for Medicaid. This is a woman named Mollie Orshansky, who worked in the Social Security Administration in 1963. She was responsible for overseeing a project to define poverty, the federal poverty line. And it's interesting to see how it was done. There was at the time in the Department of Agriculture a definition of the emergency need for food. If you were in desperate shape, what was the minimum amount of food you needed? The so-called thrifty food plan. At that time, it was estimated that the average family spent about a third of their post-tax income on food. And so what Mollie Orshansky did was multiply the minimum food requirement budget by 3 and define that as the poverty line. That, more or less, is still the way we define poverty in this country. Meanwhile, with a very stringent definition of poverty, something that nobody on this phone could possibly live on comfortably, we have continued with regressive financing policies. This was the U.S. tax rate by income in 1950. This is the same in 1980, 60, I mean. This is what it became in 2016. This is what it is in 2018. U.S. tax rates by income have remained the same or higher for people of low income and have gone dramatically down for people of high income. We have regressive taxation policy hard at work in this country to continually redistribute money from the poor to the wealthy. The change in effective tax rates is shown here. Notice between 1962 and 2018, the richest 400 people in our country used to pay 54% of their income in taxes. They now pay 23%. The top 10% used to pay 43% of their income. They now spend 30%. The bottom 50% used to spend 22% in 1962, now spend 24%. We are in a country which is the opposite of progressive redistribution of wealth. And why is that important? It's important because it affects our ability to invest in the social determinants of health. This is Michael Marmot's summary. Inequalities in power, money, and resources and regressive policies give rise to inequities in the condition of life, which lead to inequities in health. This is the chain of effect that I can't get away from when I look at the data. Regressive financing social and tax policies, deepening poverty and inequality, leading to more isolation, which produces despair, which is directly related to poor health. So this is reflected in our country's status in the world. Our child poverty rate is the second highest of 35 nations in OECD studies, and our child well-being index in the United States ranked in the 2013 rankings. This has not changed. We are last among 20 nations. We are not a nation which invests in providing supports at the level that other countries do to mitigate these effects of social disparity. The effect on children is dramatic. This is the decline in percentage of children earning more than their parents year on year. Again, regressive financing at work. Healthcare is part of the problem, not the only part. This is Betsy Bradley's study, which you've all seen many, many times, showing that compared to other countries, the United States invests far less in social determinants and far more in healthcare than other countries do when you look at the total investment in the determinants of health. What we get is what we have invested in, a high level of disparity and the consequences mediated through poverty and isolation. It doesn't have to be this way. This is the policy of the Treasury in New Zealand. A well-being approach can be described as enabling people to have the capabilities they need to live lives of purpose, balance, and meaning for them. We're not doing that well, and if we want change, we're going to have to understand the strong connections between social policy, redistributional taxation policy, and the well-being of our society through many mechanisms, not just loneliness and isolation. With that stage setting, hopefully not too depressing, I'll turn it back to you, Catherine, and look forward to hearing comments from people that are now actually trying to do something about this.